Ladies and gentlemen, thank you for joining the Patient Motivational Interviewing Conference. Your host for today, Melissa Ottinger, will now begin.
Good afternoon. This is Melissa from the Disparities in Cardiac Health program. I want to thank everyone for joining. Today's call is a collaboration between the Cardiac Learning and Action Network, the Disparities in Cardiac Health program, and the Prevention Learning and Action Network. Before we begin, I have just a few announcements. For cardiac LAN practices, your Quarter 6 data submission reports were due June 30th. Completed reports can be faxed to Tiara at 248-465-7428. If you have any questions, you can call Tiara at 248-465-7324 or Ashley at 248-465-7363. Please include your baseline for 2013 and Quarter 5 if these haven't been submitted. Also, on October 18th, the Cardiac Learning and Action Network and the Disparities Cardiac Health Program will be having a collaboration conference in East Lansing. More details and information will be coming soon, but if you could please save the date, that will be an all-day conference. Some announcements for the Disparities in Cardiac Health program. The data submission for the second quarter was due July 15th. If you have not submitted data, please do so as soon as possible. And for any questions or technical assistance, please email the DACH program at dash@mpro.org. Our next webinar for the Disparities in Cardiac Health program will be August 21st. We'll be hosting a webinar on meaningful use, PQRS, e-prescribing, and the Plan Do Study Act model. If you have any questions that you would like answered, please email those also to dash@mpro.org. In August, there will be a special edition newsletter with a focus on nutrition and health. Look for helpful resources for patients and a personal testimony on plant-based diets. The DASH team will be doing a blood pressure screening on Belle Isle, July 27th from 8:30 to 12:30 during the MOTEP Lights Walk. If you would like to be a volunteer, please contact a member of the DASH team. And also, Governor's Award of Excellence overview and guidelines have been distributed. If you have any questions, please contact me at mottinge@mpro.org, or you can call me at 248-465-7334. Prevention LAN announcements. Archived educational sessions are available now at mpro.org. You can access previous webinars and teleconferences about prevention LAN topics and PQRS. You can also connect with the Prevention Learning and Action Network blog, and also they'll be featuring podcast series. And as always, you can visit mpro.org for any information. I would now like to introduce Danielle Loosebrook. Danielle began her career in health economic and outcomes research 15 years ago. Her focus has been mostly on quality improvement in chronic illness and mental illness. She specializes in research translation, which speeds up the cycle of bringing research to market by transferring research in practical and implementable outcomes.
Hello, everyone. It's an honor to be able to present to you today. Today we're going to cover improving patient interviewing techniques by using motivational interviewing, which is also known as behavioral interviewing. My name is Danielle Loosebrock. I actually work for Boehringer Ingelheim, which is a pharmaceutical company that specializes or focuses on chronic illnesses and chronic conditions and bringing medications to the marketplace that can help in that space. So today we're going to do a very high-level overview of motivational interviewing. When I think about motivational interviewing, typically training programs for MI programs typically last 2 to 3 hours for a nice, more detailed overview. But today we're going to try and keep it to about a half an hour. And because of that, we're going to do a high-level overview of the research around motivational interviewing, and then we'll go into a little bit of detail around what some of the techniques that are used in motivational interviewing are. At the end of the presentation, I will have my contact information. If you would like more information about motivational interviewing, or if you'd like me to come and do a presentation for your organization that is more detailed, more workshop-oriented, I would be happy to do that. Just take down my contact information at the end, and we can move on from there. So to get started, motivational interviewing was really founded by Stephen Rollnick. The presentation that you're going to see was approved and sort of endorsed by Stephen Rollnick when BI was thinking about what we could bring to the marketplace to help with medication and treatment adherence for chronic illness. That is a big concern. And when we were trying to think of what kind of improvements or programs are out there to enhance patient engagement and patient adherence to all treatments that are prescribed, this was motivational interviewing or behavioral interviewing was the one thing that kind of bubbled to the top with really solid research behind it. And it's been in the marketplace or been around. It was founded 25, 30 years ago. So really, Stephen Rollnick, along with some of his colleagues, have been, bringing psychoanalytic or psychotherapeutic techniques used in psychotherapy to the general medicine area for quite some time. And now, with health reform and a lot more focus on treatment adherence and getting the best quality outcomes, I think you're seeing a resurgence in the marketplace for this particular technique to improve patient interviews. So Stephen Rollnick founded also the Motivational Interviewing Network of Trainers, and BI will be working with that organization also across the country to get the word out and training programs in place around motivational interviewing so that the patients with chronic illness have a little bit more resources. The people who work with patients with chronic illness have a little bit more resources around this particular intervention or program. So today what we're going to go over is kind of understand how motivational interviewing might help facilitate better patient-provider communications, address medication and treatment adherence and its effect on health outcomes, improve patient satisfaction and autonomy, as well as learn how you might be able to practically apply MI in everyday practice. So without further ado, we'll get into that. Some of the benefits of motivational interviewing, if you look at the literature of controlled clinical trials, focus on increased medication adherence, which sometimes has the potential to reduce risks of hospitalization, ER visits, other typically high-cost modes of care, improved patient satisfaction and autonomy. In particular, there have been some studies that look at HCAP scores, as well as patient-reported satisfaction and feelings of autonomy and empowerment. It has also been linked to better engagement in disease management programs. So the comprehensive disease management programs that you'll see for cardiac care or diabetes or COPD. And also, behavioral interviewing can help with some of the self-management support criteria for patient-centered medical home certification. There is a lot of movement in this area as well to get programs up and running that put the patient at the center. And I'm sure many of you on the phone are working toward those goals right now in your organizations or have been recently working toward those goals to become certified. Specifically, when we think about motivational interviewing, BI's program, where we bring different tools to the marketplace around behavioral interviewing, as well as understanding motivation and assessing motivation for change, we call our program InStep. And so as we think through or thought through and consulted with quality organizations around which sort of actions that are kind of encouraged through InStep, our program, essentially we wanted to tie that to quality goals. And so as you can see, there are many different quality goals that InStep and motivational interviewing can help an organization achieve. So it can improve patient experience of care, which can have an effect on CAPS and HEDIS scores, as well as the NCQA, ACO quality goals. It can help support the implementation of CQI programs, which is a specific standard for NCQA PCMH recognition. It can help activate the patient and get them to be more engaged in their own care. And that is tied to NCQA diabetes and heart and stroke recognition criteria, as well as help meet the requirements for patient-centered communication, as well as patient education and self-management, which is tied to Joint Commission advanced certification in COPD in particular. In terms of the background or the clinical studies associated with motivational interviewing, there have actually been quite a few randomized controlled trials in the literature that have been published looking at the effects of motivational interviewing versus standard care. And the first study that I'd like to share with you actually found that they were looking at antiretroviral therapy among patients failing or initiating ART, and what they found was improved adherence. You can see by the chart down at the bottom that the motivational interviewing group saw a 4.5% increase in their mean adherence to their treatment plans, whereas the control group actually saw a decrease. And even though this wasn't statistically significant, the difference between these two groups, it did trend in that direction. But I think the more interesting information from this particular study is that when you look at very high levels of adherence, which is what you're really shooting for with your patients, you'd really like them to be adherent most of the time and taking the medication or treatment program that you've prescribed most of the time. And when you look at the literature, normally a threshold for adherence is about 80%. That means 1 out of every 5 days you're probably not adherent. That's probably not ideal, but it's better than 50 or 60% adherent, and so that has been the goal for several years, in particular for medications. But this study also looked at setting that bar much higher so that you can get the kind of outcomes that you want with your patients. And so they set the bar at greater than 95% adherence. And when they controlled for ethnicity, what they found is that the MI group was 2.75 times more likely to achieve that higher threshold of adherence than the control group. And I believe that part of the reason why you're seeing MI out in the marketplace right now is because of differences like this. When you're really trying to push individuals to kind of get engaged in programs and really be adherent to their treatment and get more involved or feel more empowered to take control of their own health, really what you're looking at it is trying to get them to adhere to all aspects of treatment most of the time, almost 100% of the time, in order to achieve the type of quality outcomes that we're looking for as clinicians or practitioners. And so these are the types of results that kind of helped MI become a little bit more noticed in the marketplace. In addition, there was a very large study done with Aetna members, and Aetna basically applied MI techniques to disease management. And what they were looking for is they wanted more participation in their disease management programs. And what you can see down at the bottom is before the MI program, they had about 53% participation in disease management programs or case management disease management programs. And after MI, they saw a jump to about 76% participation within the program. But in addition to that, what they also saw was that program dropouts actually started declining as well. So not only did they get greater participation from more members that they wanted in their programs, but those members who participated in the programs actually stayed in the program longer. So there was that's a double bonus, for these disease management programs, because you're getting more people treatment and they're staying in the program to see the benefits of those programs longer. When you want to understand the difference for motivational interviewing, we can look at a couple of videos to actually kind of better understand the differences between the programs. So I'm going to actually pull those in right now so that we can kind of understand the differences of the motivational interviewing, using a motivational interviewing approach versus a traditional biomedical approach. So this first video we're going to watch is looking at a traditional biomedical approach. I will say that there are a lot of different techniques that are used in this video to kind of illustrate some of the things that can happen in a patient interview that may not be as encouraging and supportive of that patient as you might like. And so, just please know that we don't think that all patient interviews look this way. So.
Okay, so I wrote a prescription for an antibiotic for Aiden that should help with the ear infection, but in looking through the chart, I mean, it seems like he's had 6 or 7 of these just in the past year or so.
Yeah.
That's really a big problem.
Yeah, it's pretty stressful for both of us. He gets really upset.
Well, one of the primary risk factors for multiple ear infections in kids is actually smoke exposure. Are you smoking?
Yeah, I do smoke, but I don't smoke around him. I try really hard not to smoke around him.
Well, the fact that he's having these ear infections is indicating to me that he is being exposed to smoke. And so what can you tell me about that?
I don't know. I mean, I try really hard not to smoke around him. I don't smoke in the car. When he's home, I go outside to smoke. I know it's bad, and I know it's bad for him, so I don't want him to be around it, so I try really hard.
I really need you to quit smoking, both for your health and for Aiden. Did you know smoking around your child is associated not only with ear infections, it could get to the point where you have to put tubes in his ears pretty shortly here, but also things like vitamin C deficiency, cavities, like dental cavities, behavior problems, asthma, other upper respiratory infections. It's really putting him at a lot of risk. In addition to that, kids of smokers end up smoking themselves. Do you want him to grow up to be a smoker?
No, but I don't smoke. I've thought about quitting, but it's really hard, so I just don't know how to do it.
Well, now's the time to quit. It's really gotten to the point where you can't keep smoking. Not only for him, like I said, but also for you. You're putting yourself at risk for lung cancer, for emphysema, for oral cancers, for heart disease, for all kinds of things.
I know. I've heard, people have told me before, I've heard all that. I just don't know how to do it. How am I supposed to quit? It's so hard.
Well, there's all kinds of things you can use now. It's not as hard as it used to be. You can use nicotine replacement. There's patches, there's lozenges, there's gum, there's the inhaler, there's nasal spray. We can talk about medications. You can try Chantix, you can try Zyban. There's quit smoking groups you can go to. There's hotlines you can call.
I just don't have time
There's
for
no
any of
reason
that.
why you shouldn't be able to quit. This is really important.
I understand that. I know it is. Everybody has problems, right? It's really, really hard.
Well, what can be more important to you than the health of your child?
I don't know.
I really need you to tell me that you're going to quit smoking. This is really important.
I'll go look at all those things and I'll try to find something and I'll talk to my doctor about it.
Okay, well, I think you really need to think about this seriously. Like I said, it's really putting yourself and your child in danger.
Okay. Whatever. Okay.
Okay.
Okay. I hope everybody was, I saw that there was a note that people may not have been able to hear. I hope everybody was able to hear that. You may need to turn up your, on your own computer, turn up the volume fairly loud. The video is a little quiet when you're listening to the video, so you may need to turn up your volume. Phone lines, but is working on the computer speakers. Okay, perfect. I think that's what I was trying to explain. So essentially in that video, the practitioner or clinician went through a series of options for the patient. So, tried to help her understand that it's really bad for her son, it's bad for herself because of smoking, and it becomes more important for the actual patient to kind of quit smoking, and the woman says, well, it's really hard. I did it when my baby was young, but now, I don't smoke around him, and so I don't think it's a big deal. And he has, his other friends who have parents who don't smoke don't get ear infections too. So, I don't really believe maybe that my smoking is affecting my son, and furthermore, I think it's really hard to quit, and I can't. And so the clinician provides a lot of resources and really firmly says you really need to quit smoking. I can't, it's bad for your son's health. I don't understand why you can't do it, because there are lots of options out there for quitting smoking. And you can see through the patient in the video her sort of reaction, like she sort of shuts down and she has more closed body language, and just feels sort of defeated. You get the sense that she's like, this person isn't hearing me. This is very hard for me, and I've tried it before, and I'll check into some things, but I don't know that I can do it. And a traditional motivational interviewing approach would look something a little bit more like this. So, again, the speakers, your sound should be coming from your computer, so you may want to unmute.
So I wrote a prescription for antibiotics for Aiden.
Okay.
I did want to talk to you, though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently, and I noticed that you had checked the box that someone's smoking in the home. So I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I've been smoking for 10 years, except when I was pregnant with him. But it's so stressful being a single mom and having a full-time job, and so that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes, yeah. Some people have a glass of wine, I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why did you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him, and on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right, yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now. I don't even know how I did it. I just did it. I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that, all the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what, I'm not going to risk that. So
the risks were so scary then that you were able to stop, but
Yeah.
they don't feel as scary to you now.
No, I mean, we're two separate people, and like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
You're doing the best you can do.
yes. Yeah.
Okay, but it sounds to me too like part of you really does want to quit.
Yeah, I know that I need to, and I keep every new year I say, okay, this year I'm going to quit smoking, but then something happens and it just doesn't.
It's
and
on your
quitting
to-do
doesn't
list,
happen.
it's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5. Kind of in the unsure area. Like, I know I've done it before, so I know I can do it, but at the same time, it just seems really hard, and it's not the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand what mommy's doing, but I just don't know if I can do it.
Okay. So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure.
So.
Well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful in their attempt at quitting. There's different medications you can try.
I don't like medicine.
Okay. There's also a lot of support groups and classes that you can take where you have other people to go through it with you, and sometimes just having that support can be a big part of it, especially for people like you where smoking is such a stress reliever.
That sounds nice, but I'm not sure if I have the time for all that.
Sure, it feels like something that would take up a lot of time and maybe not fit into your life. I wonder if we could talk about some options that might fit into your life.
That would be really nice.
Okay, well, if you're willing, then we could set up another appointment where you could come in and we could talk more about that.
I would like that. That would be great.
Great.
Thank you.
Sure.
You're still on the line.
Operator, are you still on the line?
Yes,
Hello?
I'm here.
Hi.
Is every-
None of our participants. Oh, now they can hear us. Okay, Danielle,
Okay,
we couldn't
good.
hear you speaking at all.
Sorry, I wonder if I was on mute on accident. I didn't want to have double hearing,
Right.
like hear my phone and my computer at the same time as hearing me.
Okay.
So as I was saying, the biomedical approach is very healthcare practitioner centered. Information is provided. The provider solves the problem. The provider provides a lot of direction and information. The focus is on adhering or being compliant with the prescribed treatment regimen, which may in some cases be lifestyle modifications. It can be seen as argumentative or judgmental, using persuasion or manipulation to get the patient to adhere or comply with treatment. Ambivalence toward change is seen as a problem and an issue, and sometimes the style or method of conversation is very confrontational because the provider is really trying to push the patient to make changes, and which has traditionally been seen as motivation, but if you look at it from the patient's point of view, sometimes it can be seen as confrontational and manipulative. And I think the foundation of the biomedical approach is that the healthcare practitioner or professional really expects respect and trust from the moment they walk in the door to see or interact with that patient. Alternatively, the MI approach being applied in medical care right now is trying to kind of changed the focus away from the healthcare practitioner being at the center and putting the patient at the center. So a lot of patient-centered medical homes are really embracing motivational interviewing to kind of help change the culture within their organization or within their facilities, so that it's much more patient-centric. The information is exchanged, so it's not more of a one-way dialogue. It's more focused on a two-way dialogue where you're really asking a lot of questions of the patient and really trying to work with the patient and make sure that they understand what their options are, and the patient really is encouraged to search for the right solution for them. So there's a little bit more autonomy and power, I guess, being given to the patient to empower them to take their ownership of their own health. The healthcare practitioner really is trying to negotiate with the patient a reasonable solution that will work for their lifestyle. It focuses really on adherence as much as possible as opposed to compliance. The approach is taught to be inviting and not non-judgmental. So there aren't these issues of, well, why can't you eat less, or adhere to this diet plan that we have for you, or exercise plan, or smoking cessation plan that we have for you. It's more understanding and accepting, especially of ambivalence toward change. That's seen as normal and should be expected, as opposed to something that is seen as a problem and an issue. The style used is more focused on the negotiations and really trying to work with the patient to get them to understand the impact of their actions. And I think at the foundation, really, the healthcare practitioner understands that, when they walk in the door, very quickly within a patient interview, they need to establish some respect and trust with that patient. It shouldn't be expected or taken for granted, like that it already exists. It may in many cases, but the healthcare practitioner is encouraged to kind of use the conversation to help elicit that respect and trust. So when you think about some of the kind of fundamental differences, the biomedical approach is very directive. It uses direct questions, declarative statements, and directive advice, whereas the MI approach tries to use open-ended questions, positive affirmations, reflective listening, and summaries to help, get the patient engaged in their own health care. So when we think about motivational interviewing, a lot of the reason why it's been put into place is because of non-adherence or medication non-compliance or non-adherence, as well as treatment non-compliance. But when you're thinking about medications, I think it's interesting to note that 12% of patients, when a practitioner writes a script, 12% of patients do not even fill their prescription. Even if it's called in to the pharmacy, they never go and pick up the medication. Another 12%, if they pick up their medication, they don't take it. They don't even take the first dose. Maybe, like for an antibiotic, maybe they started to feel better. Maybe they didn't really need it, but who knows? So they don't even take the first pill. And then another 29% after that may start taking the medication, but they don't take it consistently as prescribed, and they may not ever finish the medication. So for those that, when we think about compliance, we really want people who take the medication as prescribed and don't miss or skip doses on a regular basis, but that's more of a rarity. And when you think about that, what you're down to is about 25% are able to pick up the script at the pharmacy, start taking their medication, and take it as prescribed, as the physician or practitioner would suggest that they take the medication 3 times a day or 2 times a day or 1 time a day in the morning all the time. So that's 1 out of every 4 patients are actually going to be able to do that effectively. And when you think about chronic conditions, sometimes people think, chronic condition, it's going to be a little bit easier. They know that they need to take those medications, so it should go more quickly, like they should, start adhering much more quickly. But when you look at the actual rates for common chronic conditions, what you see is they hover around 50%. So here we have asthma, COPD, coronary heart disease, diabetes, and hypertension, all in, chronic conditions where the medication is a very important aspect of treatment, and still these patient populations are really having a difficulty adhering to their medication most of the time. The thresholds for these studies were set at 80%, so what we're looking at is 80%, one out of 5 days is okay to be missed. But still we're getting very low rates of adherence for these patients. And there are a lot of reasons for non-adherence, and I'm sure that you all know many of them and deal with them on a regular basis, so I won't spend too much time on that. So what is motivational interviewing? Motivational interviewing is a directive, patient-centered counseling method for increasing intrinsic motivation to change by helping the clients explore and resolve ambivalence. So what you see is that it's talked about as a counseling method or a way to have a conversation, so that you can kind of get down to the nitty-gritty of what their motivation for change might be and identify solutions with them to make those changes. The goals of motivational interviewing are to create a supportive, non-judgmental atmosphere, help patients feel comfortable to discuss, their medication use or a change in lifestyle, their diet and exercise needs, and it's really seen as guiding the patient down their path or their journey toward better health care and taking better care of their own health. And so when you increase the amount of change talk, then the hope is that you'll facilitate better outcomes in those patients that you've had these conversations. So when you think about motivational interviewing, really exchanging information is the key. You're looking for a two-sided conversation to encourage the patient to go for changing their behavior or making changes to their medication taking behavior so that they can be more adherent with the prescribed treatment regimen. Ways that you can do this is asking permission, reinforcing autonomy within the patient, applying a technique called elicit, provide, elicit. So in that exchange, what you're really trying to do is understand what the patient already knows or is wanting to know, like what information they really need to know, and then providing more information to supplement their knowledge, and then eliciting the patient's conclusions. So making sure it's very similar to like a teach-back method where you provide information, you ask the patient to repeat it back to you, and then you can clarify if what they heard or understood is different than what you wanted them to hear or understand. And so when you think about having a patient interview, when you use motivational interviewing, what the approach for that 5-minute or 6-minute conversation during the patient interview is to quickly establish rapport so that you can engage the patient in an open, honest, empathetic discussion. Step 2 would be setting the agenda. So really working with your patient to understand the direction that the conversation needs to go. So you may have a patient with multiple chronic conditions and have, a long list of things that you really, if you had all of the time in the world, you'd want to cover. But, you only have 5 to 7 to maybe 10 minutes to spend with this patient. So you really want to focus on the highest priority issues. And that is kind of a combination between what is important for the patient's physical well-being, but also addressing any major concerns that the patient has that might keep them from adhering to some of the direction or goals that we're going to set out for the patient. As part of this process, you really want to assess the importance and confidence of the patient. So, help them understand why and how they might be able to change, really understanding their motivation for change so that you can capitalize on that, understanding where they might have been successful in the past. And then planning the next steps, so help with the decision making. So once you talk through the options, really getting into, okay, well, what can we work on now? Which solution that we talked about might be the best one to move forward with now? So those 4 steps are really the foundation of the steps of motivational interviewing. In the first step, you're establishing rapport. So it's good to express empathy so that you can let your patients know that you understand how they feel. It's good to roll with resistance, so really try to avoid arguments. Try not to argue for change. That is really the patient's job to find their own motivation for change. And if they're not ready, they're not ready. And you shouldn't try to force them or really push them in the direction of change if they're not ready for change. And the foundation of all of motivational interviewing can be summed up with this nice little acronym called OARS. You may have heard about OARS in the past. It's really using open-ended questions to help understand where the patient's at, using positive affirmations to help highlight the patient's strengths and in this process of change, a little bit of reflection, so helping the patient understand that they've been heard by using short, empathetic sort of listening statements, and then summarizing what's been said and moving on. So especially in that established rapport so that you can earn the trust and respect of the patient, OARS can be very helpful in that process. But for every step of this discussion or the conversation, OARS can be applied. So probably if you want to remember one thing out of this presentation, OARS is probably the most important thing to be able to practice when you're with patients. Open-ended questions, affirmation, reflection, and then a summary. Setting the agenda. Sometimes there's a very clear direction and you don't have to have a conversation to set the agenda. Maybe there's only one thing that they came to you for. But sometimes there are choices about direction. And really, when you have those choices, it's good to talk with the patient to set the direction of the conversation and make sure that you're incorporating some of the issues that are really that the patient is really struggling with. And the only way to know those are if you can get the patient to articulate those to you, and obviously applying the OARS skills. Step 3 is assessing importance and confidence. Here, the 2 key methods are asking how important it is for the patient to change whatever the behavior is, to try and draw out the why of the change, so understanding why the patient might be motivated to change, and then asking how confident the patient is that he or she would be successful in changing their behavior. So that's really working on the how piece of the conversation. So, what has the patient done in the past that has been successful in this area or other areas of their life? And again, summarizing using open-ended questions and other OARS skills are helpful in this step. And then the last step is really planning for the next step. So helping your patients make a decision and on a particular solution. Here it's important to emphasize autonomy, use a lot of open-ended questions and the other OARS skills to help capture progress and move on to close that consultation, and then facilitate the 3-step strategy throughout your planning the next step part of the discussion. So we've broken down really a 6-7 minute conversation into 4 steps, which seems a little excessive when you think, each step might take a minute or, a minute and a half. But really, when you think about having that sort of approach to your patient interviews, the most important thing is to start practicing. So when we think about motivational interviewing, it's not something, it comes naturally. Some people, just interact with the world and their friends and family and patients all this way. It's just kind of how they were raised. But other people really have to work at it. To kind of think through, okay, I need to establish rapport, even though I'm really busy. I need to take time to check in with the patient, agree about the direction, assess the importance and confidence for making the change, and then plan the next steps in a very short period of time. And so the best way, when you look at the motivational interviewing literature, to be able to do this is to practice. And I'll leave you with a thought that practicing with motivational interviewing can be done anywhere. I am I have 3 children, a 3-year-old, a 5-year-old, and an 8-year-old, and we practice all the time using motivational interviewing techniques so that we can have good conversations and steer those conversations in a direction to help the children make good choices, right? And it's very similar to motivational interviewing. So when you think about, I don't want to practice on patients, you can practice these techniques in other places before you bring it into the clinical setting, or you can practice with patients in general. But these are pretty good life skills too. So if you have kids like me, you may think about practicing at home a little bit too. So just to summarize, in terms of the benefits of motivational interviewing, MI can help by empowering patients to recognize and address their own barriers to change. It can help address medication adherence issues and improve health outcomes. It may help increase patient engagement and disease management programs, improve patient satisfaction, which can lead to higher HCAP scores and align with some of the ACO quality of care goals that are out there now, and help meet some of the self-management support criteria for PCMH certification. And bottom line, the foundation of everything is really to facilitate more productive communications between you and your patients so that you can help them achieve their goals. Thank you so much for your time and attention. I'd be happy to take any questions that you might have.
Operator, let's open the lines for questions.
Ladies and gentlemen, at this time, if you would like to ask a question, please press the number 1 key on your phone. Again, ladies and gentlemen, if you have any questions at this time, please press the number 1 key on your phone.
And on the slide there is my contact information, just in case you would like to reach out to me and see what other materials we have to help facilitate motivational interviewing being adopted at your organization. My email is very long. I apologize for having a long name. And my cell phone is also there on the screen and will be in the slides. There are additional slides for those of you that might want to go back and look through the slides again. There is an appendix with additional information, in particular a references slide that provides more information about where you can find more information about motivational interviewing, including books, websites, and journal articles as well.
There are no questions in queue.
Okay, well, I wanted to thank all of our participants for joining our webinar today, and a thank you to Danielle for presenting. If our participants could please answer the polling questions before logging off. Otherwise, this concludes our call for today.
Thank you, ladies and gentlemen. This concludes your call. You may now all disconnect. 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 You may now all